Hi everyone, so just give me a moment to share my slides. Okay, hope everyone can see my slides. Yep,
Yes.
great. Okay, share, right. Okay, hello everyone, and welcome again to our third season actually of the APSC Cardiology webinar series. Although this year we're doing things a bit different. We're going to talk about more contemporary hot topics in cardiology. And with me today, I've got two wonderful chairs and also two wonderful speakers. I'll be speaking about heart failure for this first episode. As I've mentioned earlier, I'll have two wonderful co-chairs with me today. Number one, Dr. Eri Todakato from Kyoto, Japan, and also Dr. Misato Chimura from Osaka, Japan. And two speakers today who will be talking about topics specifically regarding HFpEF. First speaker today is Dr. Akmal Hakim Arshad from Gleneagles Hospital, Kuala Lumpur, Malaysia, who will be talking about leveraging on cardiac imaging in concomitant HFpEF and hypertension, followed by Dr. Gary Gunn from Australia, who will be delving into the topic of simultaneous versus rapid initiation of guideline recommended medical therapy, but this time in HFpEF. So a few disclaimers and housekeeping rules. The content of this webinar is copyrighted by the APSC. The views and opinions expressed are those of the faculty members and do not necessarily represent those of the APSC. This webinar is live streamed via APSC Facebook and YouTube pages, and CME points will be submitted for those who are connected throughout the whole duration. You will receive your certificate of attendance upon completing a survey sent via email post-webinar. And also, please feel free to join us via the Q&A chat box at the bottom of the Zoom page so that we can discuss a bit more about HFpEF. Just a bit of shameless advertising on our side. The upcoming episode for this season includes episode 2, which will be talking about coronary artery disease, and this will be on the 15th of October 2025. So, without further ado, let's get started. And I'd like to introduce our first speaker again, Dr. Akmal Hakim Arshad from Malaysia, who'll be talking about how best to leverage cardiac imaging when you're dealing with both concomitant HFpEF and hypertension. Akmal, the floor is yours.
Okay. Thank you, Raja Isman. So let me just try and share my slides first. Okay. Can you all see my slides clearly? Okay, thank you. So over the next 15 to 20 minutes, I will take all of you and share some of the insights and maybe some cases on how we can utilize cardiac imaging, particularly in the patient who presented with a concomitant heart failure with preserved ejection fraction and hypertension. As we all know, heart failure and hypertension somehow have an unquestionable relationship regardless of what form and variations. Majority of patients who presented to us present as a heart failure with a reduced ejection fraction or mildly reduced or preserved ejection fraction. And of course, these three entities somehow differ in terms of the epidemiological profiles, the way they present, and the mechanism. Of course, in this particular topic, the focus is on HFpEF. Of course, the impression that we have in the past and current evidence and knowledge, we know that HFpEF is not as benign as what we used to learn back in the early days. The outcome of patients with HFpEF as bad or as adverse as those in the heart failure with reduced ejection fraction. So these are the outline of my talk. So we'll talk a little bit on the introduction, the importance of understanding the pathophysiological interplay of hypertension and heart failure with preserved ejection fraction, because this is extremely core for us to totally understand and how we utilize the cardiac imaging of choice to make diagnosis, assist in the management, and of course, observing the outcome of our therapeutic intervention. And of course, echocardiography is the first line tool. And there are various parameters or echo parameters that we need to be familiar with when it comes to the diagnosis of heart failure with preserved ejection fraction. And beyond echo, we need some advanced imaging. And to say that we only needed echo and not all the other multimodalities will be not ideal. And how we integrate all this clinical information and how this information will guide us in the treatment. And eventually I'll share the summary and practical takeaways. We know that hypertension and heart failure are closely related, and hypertension is an important risk factor for heart failure. Now, in Asia, there's a rising in heart failure prevalence. It's all driven predominantly by the rise in cardiometabolic risk factors such as hypertension, diabetes, and obesity. And one of the biggest issues is the diagnostic challenge. There's a lot of symptoms overlap, what's so-called the phenotyping of heart failure with preserved ejection fraction. Some of the echo findings itself are overlapping with one another. And the challenges of utilizing some of the sensitive component, even like your natriuretic peptides, PNP, is somehow not ideal, especially in the group of patients who are obese, and these are highly seen in patients with hypertension. And eventually, we will look at some of the multimodality imaging as the cornerstone to help us with the unraveling the pathophysiology and guiding management. Now, I'd like to share this burden of heart failure in Asia before we kick off. You see that I'm from Malaysia, and it's quite worrying to see Malaysia is one of the three highest nations in terms of the age standardized prevalence for heart failure in Asia. So it's extremely high together with Indonesia and China. And if you dive into the data that the leading causes of heart failure worldwide are seen as in the group of people with ischemic heart disease and hypertension. But if you look at the smaller distribution, for example, in Southeast Asia and East Asia, majority of the heart failure are driven by hypertension. And if you look at the one-year mortality for Asian heart failure patients, it's extremely worrying and high. So the top three tiers, Indonesia, Malaysia, and Vietnam, reaching as high as 35% at one-year mortality. And you compare that to Japan and Korea, which is extremely low, or one-third than the value. So there's a lot of work that needed to be done. And if you look at the prevalence of comorbidities among heart failure registries in Asia, regardless of where you look, the Asian HF registry, the one in Korea, the Asia Pacific, the ATTEN in Japan, the Philippines, the IDEA study in Indonesia, can see that the left bar all pointing towards one point, and that point is hypertension. And one of the impression that we always have is that the Asian heart failure patients are maybe composed of just one type of Asian heart failure patients group or characteristic, but this is certainly not the case. There is a significant heterogeneity among Asian patients. It's not just a single phenotypes in this Asian heart failure registry, particularly for the HFpEF group. I noted that the mean age at the 68 years old, so some are older, but there are also the young and the very young group, and this is driven by the rise in the presence of comorbidities, particularly the very young group. In the Malaysia Heart Failure Registry, heart failure with preserved ejection fraction composed of 20% in the subgroup of heart failure by LV ejection fraction classification. And you can see here on the right side of the chart, for heart failure with preserved ejection fractions, majority of the patients are female. And if you look again, diving into the comorbidity across left ventricular ejection fraction spectrum, it is of no surprise, hypertension again raised up as the champion of the comorbidity that drives the hypertension. Now, I personally feel that it's very important for us to understand the pathophysiology, that interplay of the hypertension and heart failure. Now, hypertension-related cardiac remodeling is indeed a dynamic process with a different phenotypic transition. We know that the pressure overload will lead to concentric LV hypertrophy, and this somehow lead to diastolic dysfunction. There's a reduction in the relaxation of the left ventricle. There is an increase in the filling pressure of the LV chambers. And this is independent of the contractile function of the LV itself. And there are various postulation and observed and published data on how these are being driven. We can see here there is an element of neurohormonal activation. So the RAS activation play an important role. But beyond that, there is a pro-inflammatory or systemic inflammation that is ongoing. And I think we need to spend a little bit more time on this particular chart. We know that LVH is a cornerstone of the transition from hypertension to heart failure. And this is a condition where you get an increase in the cardiac mass, and the cardiac mass is characterized by increase in the cardiac myocyte size and myocardial fibrosis. And there is this component of remodeling. So if you have increased cardiac mass, it will lead to LA myopathy and dysfunction and lead to LV hypertrophy. And depending on what type of remodeling that you will have, if you have concentric remodeling with LV diastolic dysfunction and cardiac fibrosis, these are the group that you'll see in your clinical practice with heart failure with preserved ejection fraction. In the group with eccentric remodeling. And if it's driven by a component of ischemic heart disease, inflammation, endothelial dysfunction, atherosclerosis, they will end up with a heart failure with reduced ejection fraction. And what is important to note that the character, so in order for you to make a diagnosis for someone with hypertension, HFpEF, first, they will have LV hypertrophy, and then they will have LV diastolic dysfunction, and they also have element of cardiac fibrosis. So these are the target parameters that you need to look at, particularly when you are targeting your cardiac imaging or investigation armamentarium to look at the component of the presence of LVH, the diastolic dysfunction, and cardiac fibrosis. So I would say that for LVH and LV diastolic dysfunction, still the echocardiogram is quite strong. It's very robust. It plays an important role. But then for the presence of cardiac fibrosis, there are more advanced imaging such as cardiac MRI that you can utilize to support your diagnosis. Now, the other important things to note is that the cardiac remodeling is very common in patients with heart failure with preserved ejection fraction in Asia. And the annoying things or the important findings is there are regional differences, not just in the region alone. So if you look at the way how the left ventricle responds to the pressure overload, and the RAS activation, you will see that some will end up with concentric remodeling, some with concentric hypertrophy, some with eccentric hypertrophy. And this distribution are seen across, as you can see, in the Northeast region, South Asia. South Asia has got a lot more concentric hypertrophy. And if you dive into the local data of the racial distribution or ethnic differences, you still see some difference. And that alone will make it very difficult for us to have a unifying single diagnosis entities so that we can have a diagnosis across all the particular group. And I like to share a clinical scenario. It's always nice to do this so that you can put yourself in the pilot mode. So this is a typical patient that comes to our emergency department. So for this patient, it's a 55 years old lady. And majority of the Malaysians ladies who come with such a presentation tend to have a high BMI. So this lady has a BMI of 28, which is extremely high for Asian standards. And there's a she has got a long-standing history of diabetes, dyslipidemia, and hypertension. And in the history, we know that she's got poor compliance. And I can share with you that in the Southeast Asia region, this is probably one of the biggest challenges that we have, is poor compliance with hypertension therapy. So she presented to our emergency department with symptoms of fatigue, lethargy, headache, and exertional dyspnea. She also has some element of mild CKD. And here the blood pressure at the time of presentation is 198 or over 118, which is not unusual. I see this all the time. In fact, in my practice, in 1 week of my own call, usually we will see majority of the patient who presented in such a way. She was admitted and treated as hypertensive emergency during the time. And you can see here in the parasternal long axis view, of the echocardiogram showing a very fee. You can see that the size of the LV chamber is still within the normal range. There is some slight enlargement of the aortic root. The LA, at least from this three-chamber view, doesn't look too bad. But when you look in the four-chamber view, there are some elements of left atrial dilatation or enlargement. This is what we call a clinical phenotype of hypertensive heart disease with a concentric LV hypertrophy. So we say concentric because the size of the internal diameter of the LV are within the normal range, but the thickening of the LV wall itself are significant with raise in LV mass. In some of the patients with hypertensive heart disease, they also have aortic root enlargement with the presence of mild AR. For this patient, when we assess the transmitral inflow, looking at the E wave velocity and the A wave velocity, you can see that here the ratio is certainly more than 2 with a restrictive pathophysiology or physiology. And straight away that there is an element of fulfilling the criteria of LV diastolic dysfunction grade 3. Would you call this patient a HFpEF now? Would you now include this patient as a hypertensive heart disease with HFpEF? What's your management plan for this patient? Would you like to do further tests? Will you add on natriuretic peptides? Is there any additional imaging that you will send? How about coexisting ischemic or coronary artery disease, which is seen as a high burden in such a group of patients? Are you happy and satisfied at this stage, or would you like to exclude other possible phenocopies, we call, or something that mimic the presentation of HFpEF, for example, an amyloidosis or hypertrophic cardiomyopathy, or even Fabry disease in such a setting? So this raises up a challenge of diagnostic challenges in someone with concomitant heart failure with preserved ejection fraction and hypertension. So we all know that the universal definition of heart failure, to simplify, the patient first must have symptoms. Number two, they will have signs of heart failure, and these signs of heart failure are characterized by systemic congestion. And the recommendation, at least by the AHA and the ACC group, is that you need to look for evidence of structural or functional abnormality on echocardiography. And if you look at the example given, predominantly LVH, increase in LV filling pressure, LA dilatation as a marker or surrogate marker of raised LV filling pressure. And then they also recommend the usage of natriuretic peptides. But some of these elements or components have limitation. So if you look at patient who has got a very high BMI, there are more and more data now showing that they don't stimulate or raise up as much natriuretic peptide response as high as other patient who doesn't have a high BMI. In fact, some of the in vitro studies shows that these free fatty acids from the adipose tissue due to the high BMI actually suppressing the release of the BNP or natriuretic peptide, so you don't get the level as high as what you expect to see. And in such a scenario, some of these patients are excluded and not diagnosed as HFpEF just because their natriuretic peptide value are not considered significant. There are some HFpEF scoring system that I will go through with you in a bit. And it's not my intention to bore all of you with the HFpEF scoring system, but it's really just to raise up the impression that there are various HFpEF scoring system out there. You can choose whichever that you find very easy to remember or to practice in your setting. And the reason why there's such a scenario is because there are many differential diagnoses of HFpEF that you need to look into because they all have different therapeutic target and treatment. And maybe that's the reason why in some of the trials you don't get a good response when you lump all this group of HFpEF together because they have a different underlying etiology and one medication doesn't serve the whole group of the different patient who share similar HFpEF characteristics. So there are the cardiac group, myocardial. This is the one with the restrictive cardiomyopathy features such as cardiac amyloidosis, your infiltrative disease, the Fabry's disease. You have your hypertrophic cardiomyopathy, those with ischemic heart disease, and pulmonary arterial hypertension. There's also the cardiac non-myocardial, those with valvular lesion, pericardial disease, constrictive and effusive constrictive pericarditis, and the group that is non-cardiac, such as pulmonary disease, anemia, or venous insufficiency. I'd like to brought you to this particular paper written back in 2022, giving her opinion on phenotyping of heart failure with preserved ejection fraction. This is an initiative trying to use machine learning or phenotyping, looking via an AI. But if you look at the far left, I really like this approach on the clinical phenotyping and etiological phenotyping in patients with specific HFpEF etiology. So the clinical phenotype, you will see there's a lot of overlap. Patient who present with systemic hypertension, those who has pulmonary hypertension, those with atrial fibrillation, or even coronary artery disease. Some of them will have an overlapping echocardiography parametrics. Those with etiological phenotype, particularly paying a very close attention to amyloidosis now, especially the ATTR amyloidosis, because there are therapeutic treatment available. Hypertrophic cardiomyopathy with the presence of now mavacamten is indeed very important, because you do able to change the outcome of the patients once you get them to the right diagnosis. So the role of echocardiography is massive, not just phenotyping and prognostic assessment, but there are various additional markers of prognosis. So it's not just limited to your LV wall thickness or LV volume or LV mass. Now we are going towards more detailed additional markers of prognosis that has evidence that can be used for prognostication. One of the recent write-up is by the American Society of Echocardiography. I think this is shared to me by Raja Esman in one of the WhatsApp group, looking at the algorithm for heart failure with preserved ejection fraction diagnosis. And one of the important components is that first, you must look into the history and physical examination. Patient must have symptoms, so not necessarily that they have a feature, say LA dilatation or even LVH, or and you start calling them LV diastolic dysfunction. And look them up into the HFpEF group, and then of course the comprehensive echocardiogram. And if you look at the mid part of the algorithm, there is a various component. You need to exclude significant mitral stenosis, primary mitral regurgitation, AS, AR, and TR. That means primary valvular lesions. You need to exclude significant coronary artery disease. You want to exclude non-cardiac pulmonary hypertension. You want to exclude cardiac amyloidosis and hypertrophic cardiomyopathy. And on top of that, pericardial constriction. So you can tell just from this mid-segment alone, a single entity of imaging modality is not enough. You will need to venture beyond your echocardiography as your first tools towards all the other features of imaging modality, which include your MRI, include your cardiac CT, include your SPECT and scintigraphy. And of course, these are all advanced images that you may not be familiar with or may not available in your center, but you need to acknowledge their presence and maybe refer your patients to those centers that have such facilities. And then if you look at the third component or the fourth component is the algorithm for the left atrial pressure estimation. And the keyword here is the elevated LAP. HFpEF is confirmed. In those groups that you do not get a character of left atrial pressure elevation, then there are additional tests that you can do. Here is a diastolic exercise echo or even an invasive hemodynamic assessment. If all these are negative, you can just come up from this loop and say that the patient have a non-cardiac dyspnea. If you look at the EA CVI, diagnostic workup for HFpEF, you will see that similar approach are being made. So again, on the left upper part of the algorithm, echocardiography is used to define the cardiac structure and function. And important to exclude the other cardiac disease. And at the very bottom, there is a diastolic stress test echo together with the right heart cath. In the scoring system that is being recommended, there are various scoring systems that exist. So you can use the HFR-PEF diagnostic algorithm. And again, the approach is the same: initial workup and diagnostic workup. In the diagnostic workup, they are dividing it into certain criteria that divide into major and minor criteria. And again, the higher you score in terms of the point, it will be pointing towards the HFpEF. And here they're looking at different component, functional component of the elevated LV filling pressure, the morphological sequelae of that, which is the enlargement of the left atrial size and the raise in the LV mass index. They look at the biomarkers such as elevated NT-proBNP or BNP. And of course, in patients with AF, there are different thresholds that they deploy. In the simpler version, also known as the H2 PEF score, this is proposed by the Reddy and the group. They're looking at simplifying how we diagnose patients. PEF score, where the H2 stands for the heavy or high body mass index, hypertensive, being on 2 or more antihypertensive medicine, and they give a point with a weighted score of 0 to 9 with 6 clinical variables, and a score of 5 again indicates high probability, score of 2 again indicate low probability, and the one in between give you a 40 to 80% likelihood. And if you compare between the ACC, AHA, and Heart Failure Society together with ESC, again, the approach are the same. And the reason why these are being done is because there are so many heterogeneity and the differential diagnosis trying to point down to this particular group. Now, one of the important components is the mechanism of diastolic LV dysfunction. And that includes your impaired relaxation, increased diastolic stiffness, and loss of restoring forces. All this lead to LV filling pressure. So your echo is the main investigation mode for you to start picking up all these signals. So we look at the element of mitral flow velocity of the E and the A wave. Can look at the E prime value or the TDI, tissue Doppler imaging at the mitral annulus to detect the presence of LV stiffness and failure of LV relaxation. Then you have a marker such as TR Vmax or tricuspid regurgitation velocity. And now there's a lot more usage of left atrial strain or left atrial reservoir strain, which some of the centers may or may not have. And there are moves of utilizing the AI in this particular group. I think one of the key here that I wanted to emphasize is the compulsive attitude of the person who's performing the echo. So you need to get a good images. Here, reduce E prime velocity, average below 6.5 cm per second are key numbers together with the E over E prime ratio of more than 14. It has a very high specificity for increase in the LV filling pressure. In the transmitral flow inflow evaluation, if you have someone with a mitral EVA velocity of less than 50 cm and a mitral EA ratio of less than 0.8, you can consider that as normal. And those with a mitral EA ratio more than 2, this indicates markedly elevated left atrial pressure. The peak TR velocity, the cutoff point is 2.8 meter per second. The LAVI, the index left atrial volume, the magic number is more than 34 millimeter squared. As for the LAS, is less than 18%. And the reason why I rush this through is because I want to reach this particular diagram. And I can tell that a majority of echo practitioners are very familiar. But of course, nowadays, with all the different subgroup, clinical practitioners. Sometimes they don't like this kind of chart. But I will say that one, if you focus on the mitral EA less than 0.8, and if your peak velocity is less than 50 cm squared, you can see a cm per second, can say that these are normal filling pressure. Whereas for those group with the mitral EA more than 2, you have an elevated filling pressure. In those group that doesn't fulfill these two criteria, you apply the additional criteria in the middle, which is the E over E prime of more than 14, or the TR velocity, or the index LA volume. And if you fail to reach the diagnosis, you can add on the LA reservoir strain to replace the missing parameter. The American Society of Echocardiography has published this recent paper trying to simplify. So maybe the best component is the E prime as a marker of impaired LV relaxation. And maybe that's the first step that you look at. And if you are able to get this value impaired below 6 or below 7 for the septal and lateral, or average below 6.5, then you go to step 2. And then step 2, you're looking at the marker of LA and LV remodeling and elevated LAP characterized by this value that you can see here. And diastolic dysfunction are present if they fulfill the criteria. And again, this is the proposed LV diastolic function grading and LAP estimation. And I want you to focus at the very bottom that in the group who only have a reduced E prime only and the EA value is less than 0.8, these are the grade 1 patient with a diastolic dysfunction. And if they are symptomatic and you want to prove that they have that, you may need to go down the route of diastolic exercise echo. So diastolic exercise echo, by right, is the most validated protocol. We perform this in the bicycle semi-supine exercise testing. You start off with a 25 watt load and you gradually increase it every 3 minutes to 25 watt. You look for the response, and the response that you want to see is an elevated average E over E prime of more than 14, more than 15 with exercise. You want to see a peak TR velocity of more than 2.8 meter per second in this particular group patient. And there are those patients who doesn't have response and you want to exclude, then you can consider sending them for invasive hemodynamic testing. And you consider this in those patients that has a discordant or indeterminate data from the imaging, or when you are considering etiologies that can mimic HFpEF, such as a non-cardiac pulmonary hypertension, those with obesity, lung disease, or mitral regurgitation. And the cutoff point in the invasive hemodynamic measurement during exercise is the pulmonary capillary wedge pressure of more than 25 millimeter mercury. That's when you make a diagnosis of HFpEF. And sometimes the key here is to not forget the value of deformation imaging, speckle tracking, LV global longitudinal strain that also have some value. Now, beyond echo, there are advanced imaging and certainly cardiac MRI come into play. So cardiac MRI is a gold standard imaging modality in assessing the atrial and ventricular volumes and ejection fraction quantification precisely without any issue of operator error or operator dependent. It allows a morphology, functional assessment. You can assess for coronary perfusion, can assess for viability, the tissue characterization, differentiation of different phenotyping of cardiomyopathy, all done in a single examination. And that brings you back to the earlier algorithm of FPEF from the American Society of Echocardiography, of the need for you to exclude many cardiomyopathies before you go down to the diagnosis of HFpEF. And of course, the gold standard is in the LV mass measurement very precisely in terms of geometry and high accuracy to differentiate between your eccentric and concentric LV remodeling. The other component of the cardiac MRI that has an added advantage compared to the other imaging modality is the powerful capability of providing tissue characterization. And this is with the interpretation of the late gadolinium enhancement pattern. So you can see in these two top images of a patient with hypertrophy. In the late gadolinium enhancement, there are significant patchy and diffuse mid-wall fibrosis, which is a character of hypertrophic cardiomyopathy. The two bottom pictures is an images of blood pooling and rapid washout of the gadolinium with diffuse subendocardial enhancement of the myocardium, characteristic of amyloidosis infiltration. And of course, not only that, this help with the cardiomyopathy phenotyping, also add value to the diagnostic workup of HFpEF, especially in unmasking the alternative diagnosis. There are additional components of cardiac MRI, and this include the T1 mapping and the extracellular volume measurement. And I believe to date, CMR is the only imaging modality that provide direct assessment of replacement and interstitial fibrosis. So T1 mapping is a myocardial tissue relaxation time characterized or presented in pixel intensities with modified look-local imaging. And native T1 value increase in various cardiomyopathies condition. And there has been many studies showing the ability for the T1 mapping and the ECV in differentiating patient with HFpEF and hypertensive heart disease in comparison to the control group. The ability of cardiac MRI separating the ischemic cardiomyopathy pattern and non-ischemic cardiomyopathy pattern is extremely valuable. At the top part, you can see amyloidosis is characterized by global subendocardial late gadolinium enhancement. Whereas for sarcoidosis, you can have a subepicardial, transmural, or mid-myocardial LG pattern. For Anderson-Fabry's disease, usually you see this subepicardial at the infralateral wall. And for hypertrophic cardiomyopathy, you can have a mix, either diffuse, patchy, focal, mid-wall enhancement, particularly at the hypertrophic region. And you can separate this with patients who have hypertensive heart disease alone, where they tend to have a very prominent RV insertion point fibrosis with their typical LV hypertrophy remodeling. So advanced multimodality imaging require a multimodality approach in HFpEF. On the very far left is the HFpEF etiologist, looking at coronary artery disease. Of course, I highlighted the amyloidosis and sarcoid and constrictive pericarditis and non-cardiac pulmonary hypertension at the bottom. On the far right, you can see some of the components that we can use. So these ranges from echo, CT, CMR, PET, SPEC, bone and cardiac scintigraphy, and including right heart catheterization at rest and on exercise. This is another example just to show you 56.
Sorry, Akmal, just to
Yeah,
interject.
yeah,
I think
yeah.
we might be running out a bit of
Sure.
time. Probably want to wrap up in about a minute. Thanks.
Yeah, sure. Thank you so much,
Thanks.
Azman. So if I can just show that this patient with hypertrophy, normal coronary arteries, features of LV failure, LV feeling elevated feeling pressure. We can see that the global longitudinal strain shows some apical sparing, and most importantly, that the cardiac MRI are able to show features of amyloidosis. These are some of algorithm for evaluation of patient suspected or include additional modality such as bone scintigraphy. And the component that you want to look at is the ATTR cardiac amyloidosis at the bottom. Here again, putting emphasis on multimodality imaging, looking at the scintigraphy, echo, PET, and CMR. This is probably one of the last few slides that I have, Raja Isman. The role of cardiac scintigraphy with bone-avid radius traces in the diagnosis of ATTR amyloidosis. These are some of the differential diagnoses in LV hypertrophy, again with assistance of multimodality imaging. These are my last slides on summary and practical takeaways. So I can conclude that diagnosing HFpEF with concomitant hypertension is critical because of its high prevalence and associated with adverse outcome. We needed multi-parametric imaging, and that will help us with the precision medicine in HFpEF. The practical algorithm that I can conclude is in patient with hypertension and symptoms. You need to look at echo parameters for LV hypertrophy and markers for elevated LV filling pressure. And then you can utilize the HFpEF diagnostic algorithm. If indeterminate, you can consider diastolic exercise echo and invasive hemodynamic evaluation. And certainly you have to touch advanced imaging in those group with diagnostic uncertainty or to unmask alternative diagnosis or phenocopies. And multimodalities cardiac imaging is central for the diagnosis and guiding of therapy. And I foresee in the future, the AI in echo will be used for the automated diastolic and strain assessment. And with that, I'll say thank you and sorry for taking the extra time.
Thank you, Akmal. So great talk and excellent lecture. So we have been able to gain a deeper understanding of the diagnosis of HFpEF, particularly with regard to imaging, such as MRI and echo. Thank you so much. So could you kindly answer just one question from the audience? Okay.
Yeah, yeah, sure,
So
Dr. Misato. Yeah.
only one question. So, in
Yeah.
the diagnosis of HFpEF, do you routinely perform exclusion of coronary artery disease in all cases? So, if so, do you prefer to use CT, MRA, or coronary angiography?
Yeah, so depending on your local setting and your type of patient, and I would say that the burden of coronary artery disease is very high in our population. And I think that's driven by the higher prevalence of obesity, hypertension, and diabetes. We certainly will exclude the presence of coronary artery disease. And you can see that you can do that in your setting. You can proceed with a stress echocardiography to look for features of ischemia and regional wall motion abnormality. I can utilize CT coronary angiogram and also cardiac MRI. So this is really depends on your setup. I can tell you that I don't have any age cutoff. The patient in Malaysian population as early as the age of 30 to 35 already have established coronary artery disease. And sometimes we have a lot of these false positive in the stress test alone. So if the pre-test probability is very high, I will use a more sensitive and specific investigation. And I would say that even in the UK, the NICE guidelines recommend the utilization of CT coronary as a investigation that will bring in the most value. You'll be surprised how CT coronary and of course cardiac CT gives you information on the LV size, LA size, LV mass, LV ejection fraction, although of course it's not validated and not used in clinical practice. But I use a lot of the cardiac CT as a investigation tools too, totally to re-stratify them early. And we also get to evaluate the coronary artery calcium scoring in this particular group of patient, and then assist me in initiation of their preventive therapy, especially in the control of their diabetes and also cholesterol and hypertension.
Okay, thank you so much. I
Yeah.
agree with you. So thank you so much, Akmal. So unfortunately, as our time is limited, so I'd like to move on the next lecture. So next lecture is Dr. Graham from Australia. So please share your slide.
Yep. Okay. Is that
So thank you. So your topic is simultaneously versus rapid initiation of guideline recommended medical therapy in HFpEF. Please start.
okay? Well, thank you, Esman, Misato, and Eri, for this opportunity, and thank you, Akmal, for doing all the hard work covering the background of HFpEF. So, So today, I guess I'll be guiding you through the management of HFpEF, and the particular focus of this talk will be on simultaneous versus rapid initiation of guideline-directed medical therapy in this population. And before I begin, I'd like to disclose that I have no conflicts of interest in regards to this presentation. Now, this is the outline for my talk today. I thought, with regards to the topic in itself, to do it justice, I'll start by highlighting the growing burden of HFpEF within the broadest spectrum of heart failure. I promise I will not spend too much time on this one, as Akmal has already covered most of it. Then I will move on to touch on the rapid change in our approach to heart failure treatment, and importantly, the translation of this approach to our patient care these days. Following that, we'll explore the current landscape of HFpEF management, both in terms of the foundational and emerging therapies. And then I'll wrap up by talking about implementation of these therapies, the pros and cons of the different techniques. So I guess I always like to start these talks by talking about the lifetime risk of heart failure. Now, I think the lifetime risk of heart failure is actually staggering. I mean, based on large epidemiology studies, we know that it's essentially the risk of developing heart failure is really 1 in 4 people. I mean, that means that in a room of 4 people, essentially 1 out of 4 of these individuals will essentially have heart failure in their lifetime. And at any given time, 2 to 3% of the population in each country actually is living with heart failure. And this statistic in itself has been consistent throughout large epidemiology studies, and probably underestimated in some continents as well because of the different modalities in reporting. But I think what's very interesting is also that the trend of heart failure is actually changing, and amongst patients with newly diagnosed heart failure, we know that the prevalence of HFrEF has actually decreased over the last 3 decades, whereas the prevalence of HFpEF has actually increased. Part of this is because, we're looking at improved survival after the onset of coronary disease, also with an aging population, other comorbidities such as AF, diabetes are starting to catch up. And also, let's not forget that we have an increased clinical recognition of HFpEF these days, as outlined by Akmal in his talk. We have so many different imaging modalities to pick up HFpEF. And so these days, you will see over the next coming years that HFpEF in itself will become a major burden in terms of our heart failure care. Now, when we talk about treatment for heart failure, I think it's important to acknowledge that the way that we approach treatment over the last few years has actually undergone almost a renaissance, really. Now, once a diagnosis of heart failure is established, it becomes imperative for us to introduce proven therapy aggressively and optimizing doses to prevent worsening. In heart failure with reduced ejection fraction, contemporary therapy would include the 4 foundational therapies, as you can see on the left box, the 4 pillars: ARNIs, beta blockers, MRAs, and SGLT2 inhibitors. For the heart failure with mildly reduced ejection fraction, the current consensus for this group is that they be considered for the 4 foundational therapies, recognizing that there is overlapping pathophysiology and clinical benefits in this intermediate group. And when it comes to heart failure with preserved ejection fraction, the therapeutic landscape has historically been a lot more challenging. SGLT2 inhibitors are established as a cornerstone of treatment in this group, but there are newer generation therapies, such as the newer generation MRAs, which are showing promising benefits, which we will dwell into a little bit deeper in the following slides. So, we mentioned about, I mentioned earlier about the changing landscape of heart failure management. The agents that we use in treating heart failure is not the only thing that has changed. Our approach to managing heart failure has also fundamentally shifted in the last 5 years. Now, traditionally, therapies were introduced in a stepwise sequential fashion, and is usually based on a historical order in which clinical trials were conducted. But this model, we know from experience, has led to a lot of delays, underuse of effective therapy, and missed opportunities. So rather than waiting, contemporary treatments these days advocate for a simultaneous and rapid initiation and uptitration of these guideline-directed medical therapies. And perhaps the most compelling support of this multi-drug approach is seen in the systematic review and network meta-analysis seen here by Dr. Trump and his team. And this analysis essentially aimed to estimate and compare the aggregate treatment benefits of various pharmacological therapies. What you can appreciate is if you go to the top of this table that the 4 pillars of heart failure therapy at the end of the day has the greatest effect in terms of improving survival and reducing hospitalization. Other combinations of therapies are not ineffective. They are effective, but maybe not just as effective as the 4 pillars. But I think overwhelmingly, what you will see is that a multi-drug approach is actually much better than a single drug approach, as you can see as you go down in this table in itself. Now, very compellingly, we also have randomized data supporting the safety and efficacy of this multi-drug approach. And this is in the form of the STRONG-HF study. STRONG-HF, I think there's not a single person these days that has not heard of this study. It's an open-label, multinational randomized trial, and it compared a high-intensity intervention versus usual care for patients admitted with acute heart failure. The study enrolled around 1,000 patients, and then these patients were then randomized in a 1-to-1 fashion to the interventional group, where they underwent high-intensity care with rapid up titration of therapies, or usual care, which was managed in accordance with local practice guidelines. Now, participants in the intensive care group would undergo up titration of therapies within 2 weeks of discharge, followed by 2 further visits over a 2-month period for close assessment. These patients were closely monitored, and up titration of heart failure therapy was guided by the NT-proBNP levels. The primary endpoint was 180-day readmission. And what we could see was that at the end, at 180 days, patients in the high intensity group had a greater up titration of GDMT, and this led to greater reductions in NT-proBNP, which in turn translated to a significant reduction in cardiovascular death and heart failure hospitalization. The p-value was highly significant at 0.002 with a risk ratio of 0.66. And in fact, the results were so profound that the study was stopped early by the Data Safety and Monitoring Board. And importantly, relevant to this talk, the benefits were consistent across all LVEF categories, including HFpEF, with no heterogeneity in regards to the NT-proBNP tertiles. Rapid initiation and up titration of heart failure therapy was associated with improvements in hemodynamics and congestion, so it was safe and effective. We did see that there were more adverse events, but no major events that led to cessation of therapy in itself. Now, based on this data from STRONG-HF, there has been a shift. There's a shift towards early initiation of simultaneous therapy. And by starting multiple treatments sooner, we know that we can more effectively reduce mortality, hospitalizations, and symptom burden. This proactive strategy has now been endorsed by major heart failure guidelines and is increasingly seen as our new standard of care, or our standard of approach for any patients with heart failure. And as you can see here, it is endorsed by the latest, the focus update of the ESC heart failure guidelines with a level of recommendation of 1B. Now, what about HFpEF? Now, for us to understand the approach that we should take with HFpEF, I think the first thing we need to do is understand where we are in terms of foundational and emerging therapies in heart failure in this group of patients, which is what I'll be going through in the next couple of slides. So now, before we begin, it's always worth reflecting on just how recently the therapeutic outlook for HFpEF actually started to change. I mean, as recently as 4 years ago, there were no guideline-endorsed treatments. Specifically in this group, we did perform trials, but they were mostly neutral, and the management of HFpEF was largely focused on symptom control, using diuretics for congestion, and treating comorbidities such as hypertension, diabetes, atrial fibrillation. Things change, however, with the advent of the SGLT2 inhibitor, originally introduced for the treatment of diabetes. SGLT2 inhibitors has emerged as a cornerstone in the management of heart failure with reduced ejection fraction, demonstrating significant cardiovascular benefits in the DAPA-HF and AMBER-reduced trials. And these benefits extended well beyond glycemic control. Now, building on this success, the EMPEROR preserved and the DELIVER trials expanded the role of SGLT2 inhibitors, firmly established them as establishing their role as effective treatments for HEF as well. Now, EMPEROR preserved, published in 2021, evaluated more than 5,900 patients with an ejection fraction of more than or equal to 40% with or without diabetes. The DELIVER trial, published in 2022, evaluated more than 6,200 patients with injection fraction of more than or equal to 40%, including those with improved ejection fraction. In both trials, patients were randomized in a one-to-one fashion to receive either placebo or empagliflozin or dapagliflozin 10 milligrams daily. Now, these were event-driven trials, and both trials were highly significant. In EMPEROR Preserve, we saw a 21% relative risk reduction in the composite of cardiovascular death and heart failure hospitalization, and in the DELIVER trial, an 18% relative risk reduction. Now, both EMPEROR and Preserved and DELIVER trials demonstrated the improvements in the composite endpoint of cardiovascular death and heart failure hospitalization, but because the benefit was driven primarily by reductions in hospitalization, and then that sort of led to the uncertainty of whether there was any benefit in terms of the individual components of the composite outcome. They did a pre-specified pooled analysis of the two trials, and the analysis was performed prior to the lockout and unmasking of the DELIVER study. And to enhance the meta-analysis in itself, individual participant data was leveraged to harmonize the endpoints. Now, the combined cohort consisted of about 12,000 patients, and what they demonstrated was that treatment with SGLT2 inhibitors significantly reduced the risk of the primary composite outcome. There was a strong and definitive reduction in rates of hospitalization for heart failure, but although not as strong as a signal for rehospitalization, cardiovascular death alone was also reduced. Now, because of the findings of the DELIVER and EMPEROR Preserve trials, it was a pivotal advancement in the treatment of HFpEF. These findings prompted a re-evaluation of the clinical practice guidelines, and based on this robust data, the SGLT2 inhibitors has now become a foundational therapy in this population, irrespective of diabetes, of the status of diabetic status. Now, around the same time that SGLT2 inhibitors were being recognized as foundational therapies, their attention also started to turn towards another promising agent, which was finerenone. Similar to spironolactone, finerenone blocks the mineralocorticoid receptor and activation of aldosterone. But in contrast to the steroidal MRAs, finerenone had a unique binding mechanism and a distribution which increased its potency for reduction in fibrosis and inflammation. Now, the original two studies, the FIGARO-DKD and the FIDELIO-DKD, were phase 2 trials in the finerenone clinical program, and it investigated the role of finerenone on renal and cardiovascular outcomes in patients with CKD and type 2 diabetes. On the top right, the Fidelity was the pooled analysis of the Fidelio and Figaro, and it included over 13,000 patients from these two studies, which were randomized to either finerenone or placebo. Now, there were two key endpoints, which is the cardiovascular composite and the renal composite. The cardiovascular composite was a 4-component MACE, which is cardiovascular death, heart failure hospitalization, non-fatal MI, and non-fatal stroke. Now, the findings of the Fidelity pooled analysis showed that finerenone, in addition to RAS blockade, significantly reduced the risk of the composite cardiovascular outcome by 14%. It was a highly significant p-value of 0.001. The number needed to treat was around 46. But the primary driver of this overwhelming benefit was actually a 22% reduction in heart failure hospitalization. Now, the findings of this pooled analysis led to the development of the Fine Arts Heart Failure Trial, which was published recently, only the 2024 last year. The Fine Arts Heart Failure Trial was a randomized double-blind placebo-controlled phase 3 study evaluating the role and safety of finerenone in patients with symptomatic heart failure with an ejection fraction of more than or equal to 40%. And the trial in itself was highly significant, showing a 16% reduction in the composite endpoint of cardiovascular death and total worsening heart failure events. The benefit, similar to the Fidelity, was driven primarily by fewer hospitalizations and urgent heart failure visits. This benefit was consistent across all subgroups. The therapy in itself was generally well tolerated, and notably, there were improvements in health-related quality of life in patients receiving finerenone as well. And given the robust findings from the Fidelity pooled analysis, it was no surprise that finerenone earned a Class 1 Level A recommendation in the focused update of the heart failure guidelines by the ESC in 2023, specifically for the prevention of heart failure. Now, following the positive results of the Fine Arts HF trial last year, however, it is now well positioned to receive a strong recommendation as a foundational therapy for HFpEF, hopefully in the next iteration of the guidelines itself. Now, following the success of the SGLT2 inhibitors, there was growing recognition that effectively managing HFpEF requires more than just targeting the heart itself, and hence increasing attention was turned towards addressing the broader spectrum of comorbidities, in particular obesity, that not only contributes to development of HFpEF, but also significantly impacts its progression. This is the context of which the STEP-HFpEF and STEP-HFpEF-DM trials actually garnered considerable interest. These were large randomized placebo-controlled trials that evaluated the impact of once-weekly semaglutide on patients with obesity-related HFpEF, with or without diabetes, respectively. Both trials were of similar design, and the investigators enrolled patients with an ejection fraction of more than or equal to 40%. Enrolled patients were randomized to either weekly semaglutide or placebo. But it is important to recognize that these trials were not cardiovascular outcome trials. The primary endpoint was actually a co-primary endpoint of change in weight and symptom scoring. Both trials did demonstrate, however, that semaglutide significantly improved heart failure-related symptoms, physical function, health-related quality of life. Additionally, these patients had more meaningful weight loss, reduced inflammation, and enhanced exercise capacity. Post-hoc participant-level pooled analysis of the SELECT, FLOW, STEP-HFpEF, and STEP-HFpEF-DM trials was subsequently undertaken, and this encompassed about 3,700 patients, including those with obesity, type 2 diabetes, chronic kidney disease, and even cardiovascular disease without diabetes. And it showed a consistent effect that semaglutide reduced the composite risk of cardiovascular death or worsening heart failure events by approximately 31%. The benefit was once again largely driven by reduction in first heart failure events, while the effect on cardiovascular mortality alone actually did not reach statistical significance. Now, building upon the insights gained from the STEP-HFpEF program, the SUMMIT trial further explored the potential for metabolic activities in HFpEF. And the SUMMIT in itself was a randomized double-blind placebo-controlled study evaluating the effect of once-weekly tirzepatide, a dual GLP-1 and GIP receptor agonist in adults with HFpEF and obesity. The results of the trial were compelling, and over a mean follow-up period of 104 weeks, tirzepatide significantly reduced the composite endpoint of cardiovascular death or worsening heart failure by about 38% compared to placebo. This benefit, once again, driven primarily by reduction in heart failure events, with no significant difference observed in cardiovascular mortality alone. Additionally, tirzepatide, similar to semaglutide, was associated with substantial improvements in health-related quality of life and increased exercise capacity. Now, these three agents that we talked about, the SGLT2 inhibitor, the finerenone, as well as GLP-1 agonist, they were the three therapies that had garnered the most interest in the last 4 to 5 years in terms of its data and its efficacy in patients with HFpEF. But there are also emerging therapies that I'll talk about briefly. Now, inflammation. we'll start with that. Inflammation, we know that it plays a pivotal role in the pathophysiology of heart failure. We know that elevated inflammatory markers have been associated with increased mortality and hospitalization rates. And this underscores the importance of targeting inflammation. Unfortunately, early trials into exploring inflammation as a potential therapeutic endpoint has been fairly neutral, but there are ongoing concerted research efforts that have explored various approaches to mitigate inflammation. The CANTOS trial in itself is one that I would like to sort of briefly mention on. The CANTOS trial actually evaluated the role of canakinumab, an interleukin-1b monoclonal antibody. The primary focus of the trial in itself was to reduce major adverse cardiovascular events in patients with a prior myocardial infarction and elevated inflammatory markers based on the high sensitivity CRP. But a key secondary analysis of the study itself revealed that important insights into heart failure. Specifically, canakinumab was associated with a significant reduction in hospitalizations for heart failure and heart failure mortality. These findings have provided some of the earliest robust evidence linking inflammation, particularly through the IL-1 mediated pathways, to the pathogenesis and progression of heart failure. Also, AF rhythm control on heart failure. Now, we know that the EAST-AF-NET4 trial is a randomized control study that investigated early rhythm control therapy using either antiarrhythmic drugs or catheter ablation to improve cardiovascular outcomes in patients with recently diagnosed atrial fibrillation. But a pre-specified sub-analysis of the study that involved around 800 patients looked at the composite primary outcome of cardiovascular death, stroke, or hospitalization for worsening heart failure. And it actually showed that early rhythm control initiated within 1 year of AF diagnosis actually reduced the composite outcome. It is actually good to know, it's actually relevant to know that in this study in itself, though they included patients across the spectrum of the ejection fraction, more than 50% of the patients actually were at baseline had a diagnosis of heart failure with preserved ejection fraction. And it sort of highlights the importance of AF rhythm control in preventing progression of heart failure as well. So now that we've talked about the therapies, the newer therapies in HFpEF, what about implementation of these therapies in this population? Now, I thought I'd put in this figure here just to once again remind everyone that HFpEF is a progressive multi-system condition. And although with the recent advances in therapeutics, recent advances in therapies have changed the landscape of management of these patients. However, with still the data linking the therapeutic strategies have not been as robustly studied compared to the HFrEF population. Now, we know that symptom burden, functional limitation, and hospitalizations for HFpEF do begin early and they do worsen over time, leading to reduced quality of life and increased mortality. And hence, when we talk about rapid initiation of therapies, we certainly know that there is a profound benefit to be reaped. Now, we do know from those clinical studies that we talked about that the benefits of these agents actually occur fairly early in the SGLT2 trials. The therapeutic benefit, if you can see on the left, emerged as early as 2 weeks. In the finerenone study, in the fine art study, we see that the benefit actually starts occurring early, but becomes most obvious around 6 weeks. And again, similarly, in the STEP sort of HFpEF programs, we also see a similar benefit that starts to emerge fairly early, probably around 8 to 12 weeks. Now, when you think about early initiation of therapies, the idea of early initiation therapies, similar to HFrEF, is to prevent progression of disease. So in that setting, I would probably say that rapid initiation of therapy certainly does have value. We have now a chance using these newer molecules to actually change disease trajectory, to break the process of HFpEF, and essentially not only pause, but also reverse remodel, activate reverse remodeling, and thereby sort of giving us, I guess, hopefully a pathway towards, I guess, resolution of the disease process in itself. When we talk about simultaneous initiation of these combination therapies, however, I think we have to look at it in terms of a pro and a con sort of perspective. We know that with the multifactorial nature of HFpEF, yes, there is a growing interest in simultaneous initiation of these therapies because they are often driven by a complex interplay of comorbidity. So if you think about it, if you target all of them in one go, technically speaking, they should have an additive effect in terms of slowing down disease progression. And certainly we see no attenuation of treatment effect when we look at the combination of these therapies. The cardiovascular benefit of finerenone was consistent in the Fidelity pooled analysis and fine arts trial, irrespective of baseline SGLT2 inhibitor or GLP-1 therapy. The cardiovascular benefits of semaglutide was also consistent in the STEP-HFpEF trials and the Summit trial, irrespective of baseline therapy as well. But do these therapies have an incremental synergistic effect? I would probably say at this point in time, we do have limited data on that. We know that it is safe. We know that you can initiate these therapies simultaneously, but do they have the same incremental synergistic effect as the 4 pillars with heart failure with reduced ejection fraction? Now, that is going to be a little bit more difficult to answer at this point in time with our data. Also, we do know that, looking at rapid initiation of therapies, these therapies are a bit different to the 4 pillars of therapy that are mostly oral therapies. When you look at semaglutide, they are subcutaneous therapies. And so timing of these therapies in itself is also very important. When we look at safety of these agents, we know that they are individually well tolerated. They largely have non-overlapping adverse effect profiles, but I would probably also argue that volume status and renal function can be affected overall when we initiate therapies simultaneously. Also, a large proportion of our HFpEF population are older. They are more susceptible to side effects. They are more susceptible to frailty. So when you think about particularly the GLP-1 agents, remember the trials in itself were not exclusively HFpEF. It was HFpEF and obesity. And so therapies in this population, which are older and more frail, is questionable. And also there is not much data on safety of initiation of these GLP-1s in a more acute setting. Let's not forget cost and logistics. When we talk about the 4 pillars of therapy, their profound effect has led to substantial, I guess you could say, substantial cost reductions, particularly in countries with a Medicare system. However, even in countries with a Medicare subsidy, the out-of-pocket costs for these newer agents in HFpEF is usually not covered. So you're looking at insurance policy exclusions, formulary restrictions, supply chain interruptions as well. But I think the most important lesson that we should not forget is the fact that HFpEF is highly heterogeneous. So as a heterogeneous clinical syndrome, the trajectory of which is affected by comorbidities, we've learned over the years from all our neutral trials that essentially a one-size-fits-all just cannot actually be effective in this population. So I would probably say simultaneous commencement of all these therapies in itself is something that we do have to be very careful about. And perhaps the best way forward is a phenotype-based approach focused on specific comorbidities. And in this regard, we see SGLT2 inhibitors as cornerstone therapies for patients with HFpEF that confers benefits in symptom and relief and reduction in hospitalization. These therapies, the SGLT2s, should be initiated in all patients with HFpEF, and then subsequently, to avoid unnecessary pharmacological burden or futility, the subsequent therapeutic interventions should be tailored based on an individual patient characteristics. If they are obese, we can consider GLP-1 agents. If they have chronic kidney disease, we can consider finerenone. And again, if they have AF, we can consider early ablation strategies. And I think that may actually be, at this point in time, the safest way to approach our treatment, our newer treatment initiations in this population. So My take-home message is that the therapeutic landscape of HFpEF is certainly evolving, and with the evolution of our treatments, we see a paradigm change in the way we approach these agents as well. But HFpEF is a heterogeneous condition. Remember that one size fits all literally was the reason we have so many neutral trials. So simultaneous initiation of therapy, while they have potential gains, we do have to be a bit careful at this point in time. Phenotypic directed approach with rapid initiation of the foundational treatments, complemented by the selective therapies guided by comorbidities, is probably the more ideal way moving forward at this point in time. And that's all I have for this talk.
Thank you, Gary. That was perfect. Really excellent talk. Thank you so much. You covered all the essential problems. And I think this was a very tough, challenging topic because we know about HFpEF drugs. And probably maybe there are some data on rapid initiation. But to be honest, there is no data for simultaneous initiation. And of course, most guidelines don't recommend GLP-1 receptor agonist or finerenone at this moment. I think Japanese guidelines were updated just this March this year. And we were the first one to include finerenone as class 2A in HFpEF and also GLP-1 receptor agonist in obesity patients. So I think, it's a little bit tough to say, can we start these drugs simultaneously? But I think you've laid out very beautifully. So I think we have two questions, two simple ones. First one is NT-proBNP cutoff to rule out heart failure with preserved ejection fraction. Is there any change or update? Do you have any data or I think it varies in the country, but do you have anything on this one?
Yeah, I think with regards to NT-proBNP cutoffs, I think number one, I guess, in terms of the absolute values, we are still trying to see which, I guess, how many standard deviations are we going to take in terms of an absolute cutoff? But I think as a general rule, the absolute figure for NT-proBNP has not shifted substantially, at least in terms of we don't have any additional randomized data that tells us that we should change our threshold at this point. I think an important part of NT-proBNP testing is also to know, I guess, when we use what we call the symptomatic scale and the asymptomatic scales, because we do have age-related cutoffs for asymptomatic testing of NT-proBNP. And I do believe that the evidence base of that cohort would be a little bit weaker. So in that regard, I do think what Akmal spoke about in terms of combining these serological markers and imaging markers is so important. I think if somebody was symptomatic, there was evidence of congestion, we can probably say that the current thresholds we use are fairly accurate, and that in itself can already prompt us to initiate therapy at an early stage. But again, there is obviously that obesity paradox whereby the larger the BMI, the lower the NT-proBNP. Unfortunately, I wish I had more data to share with you guys in regards to that sort of population, but it is still, I think there's a lot of interest, there's a lot of work, but nothing randomized that I can share with you at this point in time.
Great, thanks. Biomarkers are very important in HFpEF. And also there are questions about SGLT2 inhibitors and finerenone. Perhaps you could answer this very briefly. So I think the one is, does SGLT2 help in heart failure without type 2 diabetes? And the second one is any role of finerenone in patient with HFpEF. Perhaps in interest of time, perhaps you could share like a trial name so that maybe, the questioner can sometimes can look back into these trials after this. Yeah, I think.
Yeah, no. I think the Fine Arts HF study was the study that looked at finerenone in patients with heart failure with an ejection fraction of more than or equal to 40%. That was the pivotal phase 3 trial that was conducted after the findings of the Fidelity pooled analysis. And in that study in itself, I think if I'm not mistaken, about 18% of patients were on SGLT2, 15 to 18. I can't remember the exact value, but I think a similar number were on GLP-1 agents as well in that study. So I guess that probably gives us the most compelling randomized data of tolerability of these three agents together. But again, I think exactly, but like how I summarized the talk, I think it's more of a phenotypic approach as to who we decide to put these patients on. But that will, I feel, also complicate clinical trials moving forward, because you see, foundational therapies mean that future trials, you need to have that baseline foundational therapies. And it's going to be so difficult when we are conducting future HFpEF trials. It really is a challenge, because what would you say is your baseline acceptance into a study in the future?
Yeah, I totally agree. So we're getting a lot of questions. So can acute heart failure be reversible? What do you think?
Can acute heart failure be reversible? So I think the data right now is to look at acute heart failure as a spectrum of chronic heart failure. So think of acute heart failure as a phase in these individuals' heart failure journey. So acute heart failure can be treated, can be reversed. But remember, once you are diagnosed with heart failure is a progressive condition. And so that's so if you think about it in that sort of timeline of a patient journey, acute heart failure is when they come to the hospitals, they're congested, they're unwell. Your job is to stabilize them, diurese them, and then start our foundational therapies to break the progression of their chronic heart failure in itself. So think of it that way. Don't think about it as acute versus chronic heart failure and whether it's reversible or not.
Great. So I have a burning question, actually, if you don't mind. So in the last week at the ESC, DAPA ACT-HF was presented. So that's initiating dapagliflozin in acute phase of the heart failure. So what they found was, it was a neutral trial, but also they found that there was an increase in hypotension. That's just 1%, but it's still there is a 1% increase in hypotension. We all know that SGLT2 inhibitors don't, among the four pillars, is not really affecting the blood pressure a lot, but still they found that this interesting findings. And the investigators commented that in acute phase, the medication for heart failure, the GDMT, should not be initiated simultaneously. It should be sequential. So what's your opinion about that?
Yeah. So I guess being mindful that this talk is recorded, let's put it that way. So I think so look at the trial in itself was fairly disappointing, but I would probably mirror the comments that that Professor Beskum, had sort of voiced in the panel commentary. Basically, this study in itself is not a practice-changing study. The study looked at safety of initiation of an SGLT2 inhibitor in patients who were acutely decompensated. A similar study, the MPulse study, had also been performed last year. And yes, the findings were significant. It showed that it was safe to do so. Bear in mind, however, that the follow-up period for these two trials were quite different. The most recent one looked at 2 months, and the last one looked at 3 months. The MPulse looked at 3 months. Their statistical analysis was also quite different. But I think if you really pushed aside the findings of the study in itself, the trial, we have so much data on SGLT2 inhibitors. In fact, I think it's probably the most studied sort of agent that we have right now. We know that they are safe. We know that they are great. They have a great diuretic effect, but let us not forget that they are not designed to be diuretics.
Yeah.
So going back to your basics in heart failure management, somebody comes congested, you decongest them to improve their hemodynamics, and then you add on foundational therapy. That should be the way that we approach these things. I think the trial landscape has gotten a little bit competitive, and so more and more of these trials are now being designed. But I would probably say we do have enough data when it comes to the SGLT2 inhibitors. We should not change the way we're using SGLT2 inhibitors, because we have actually seen them work. We've seen them change lives. Diurese your patients, get them hemodynamically improved or better, and then after that, you initiate these therapies. The sequence of therapies you would like to initiate is completely up to you, but your goal should be the 4 pillars of heart failure therapy initiated within 4 to 6 weeks of the hospitalization in itself. So to answer your question, I mean, look, it's a disappointing result, but it doesn't really change the way that I practice. I would still initiate therapy during the hospitalization, preferably right before discharge. Now, subsequent to that, I think it comes down to your logistics where you work. If you have a stabilizing platform like a heart failure clinic or a titration clinic, you can look at initiating the therapies early and closely following up. If you don't have that sort of platform where you work, you can be a little bit more careful. You can initiate half the therapies, but don't forget that you should follow these patients up to initiate the remainder of the therapies in itself. I think that's the best way to go about it.
Perfect. Thank you. So I think that's it for our question. Yeah. Okay. Well, Gary, thank you so much for a wonderful, wonderful presentation. It was really excellent. Thank you. I think we learned a lot. Okay. So Esmond, I'm back to you.
Right. Thanks, Harry, for moderating that session. And I think we are actually running a bit behind time. I really like to thank everyone for actually helping out with today's episode. First and foremost, Harry, for helping me co-chair today's session. Really, no one better than a HFpEF heart failure expert herself. And I really like to thank Misato as well, my co-director, for this particular webinar series, for helping me co-chair as well. And two shout outs to our wonderful speakers, Dr. Akmal Hakim, who really touched on a very important point when it comes to HFpEF, which is, multimodality imaging. And I think you can't get away from that. Yes, echo is really the linchpin, but there are many more things that you can use in your arsenal to sort of help with your diagnosis. Don't just stop at the HFpEF scoring system, find out the etiology and work from there. And I also like to thank Gary as well for his wonderful talk. And again, title was my idea. I really truly apologies. But it is a very hot topic at the moment with regards to how you're going to start HFpEF treatment in light of how we are doing with HFrEF. So I thought it'll be very, very poignant at this point in time. Just a shout out to everyone as well to remember our 15th of October, which is our second episode, which will be on coronary artery disease. And that particular episode will be chaired by Dr. Jonathan Yap, our other co-director. And with that, I'd like to thank everyone again and have a safe and wonderful remaining night. Thank you, guys.
Thanks, guys.